Like all these cases are treated as per the best institutional ethical norms, and I don't have any business interest, and views expressed are my personal, not necessarily my institutional views. So before we start with the soldiering, in 79 I got selected for BDS in KGMC. So after getting admission, I get a call later from the MBBS selection board to come and join the MBBS course in the government medical college, Cuttack. So it has been difficult for me to decide what to do. All my friends, they told, what is there in 32, you must quit 32, come and join MBBS, got a very wide field and all these things. But somewhat it was my inner instinct that probably with dentistry I am able to do better than doing medical. So that's what I continued. BDS was quite eventful with multiple honors and a degree. Then finally house job, which was not mandatory that time, got admission into oral surgery in KGMC. After 2 days it got changed due to a court order. Landed up in pedodontics MDS. So that's the time I decided, no, there is no point of continuing with this. So we must change. That's the change started. This is from a dental doctor to a dental officer. There is a difference between a doctor and officer. Officer means you have an office to you, office to run with a lot of financial power, with a lot of added responsibility. And after 39 years, I stand here. So now, after being into the service, again appeared the exam, got for MDS in Mumbai University, and a silver medal, that is called KS Master Memorial Silver Medal. That is what the journey started as far as the oral surgeries, maxillofacial surgery is concerned. That time the degree was only oral surgery, it was not maxillofacial surgery, it was branch 3. So the first case I operated is a case of cranioplasty way back in 93. That's in a hospital in Kalimpong, that's in West Bengal, it's a very remote area. And in 1995 I presented this case, that is on 21st annual conference. So that was my beginning as far as the cranioplasty is concerned. Since last more than 30 years, we have cases from all over the country, particularly from my setup as far as the cranial reconstruction is concerned. Gamut means you look, this is the first case I did. I took my own impression, fabricated a hot heat cure acrylic plate, fixed it with 2 pieces of wire. That is what the journey started. So here a referral from a tertiary care center with, look, this is the CT scan, hitching the dura with the acrylic plate. The good amount of dural expansion, now you can make out. Can I point to somewhere? Pointer. Okay, sure. So now you can make out the amount of dural expansion there. Okay. Look at this is the amount of dural expansion and total return of the cerebral hemodynamics. So after acrylic plate, then is the mesh. Mesh, in fact, you don't get good contour as far as the frontal projection is concerned. Then switched over to split calvarial graft. Look at the defect. First piece fixed with 2 micro screws. Second piece, third piece, you just count the number of pieces and how it has been organized. And as far as the aesthetic and outcome is concerned, there is absolutely no match as far as the reconstruction is concerned with the split calvarial graft. So here is the lateral radiograph, the donor site defect and the recipient side. Hardly there is any hardware. It is only the micro screws. So now again with the bone flap in the anterior abdominal wall, this is the defect. This is the bone flap which is there, though it is little resolved. exposure of the defect, harvesting the bone flap, 2 pieces we could harvest, and the remaining portion we picked up a split calvarial graft. Okay, here in cadaveric bone graft, preserved bone graft, sieving of the bone graft, autoclaving it, because I don't know where it has been stored, autoclaving it, putting it back. After 4 years, still it is intact, though partially it has been resolved. Okay, in children, particularly in grossly mutilated cases, it's very difficult because half of the head has been skin grafted. The flaps have been rotated. So still we tried with split calvarial graft in these cases. Look, the size of the defect is 10 centimeter, 5 pieces, and this is after 5 years. These particularly bone grafts acted as the island of growth, that is osteotransduction, completing the healing. Okay, yet another child, look at the tracheostomy wound, barely 3 years old, case of GSF, growing skull fracture, durocranioplasty. Duroplasty, for cranioplasty, we don't have split calvarial graft, so we choose split rib graft. 2 pieces of rib split into 4, put in the place. This is the child. Okay, half-headed female, all sort of combination, and the defect is just 15 centimeter plus. You can't have that much of split calvarial graft to obturate these defects. So, first is the split calvarial graft, as much as I can harvest. Then is the split rib graft, 2 pieces, and the remaining portion is with the mesh, 2 pieces again. So this is what we started and this is what we finished, and this is the radiograph, perfectly contoured. Then came to PIC, polyether ketone implants. As far as our cases are concerned in the tertiary care center, these are grossly mutilated cases what we get. So this is yet another case, already grafted with skin graft, treated with the PIC. Then, of course, nowadays is your PSI, what you call, perfect fit PSI. So with this background, I started my career as a maxillofacial surgeon, mostly working in conjunction with the neurosurgeon and with the ENT surgeons. So suddenly, one day I got a call from the Maxillofacial Association that you have been nominated for FIO BMS. During our time, there never used to be the examination. This is the first batch. We had FIO BMS. That function was held in Jaipur. The next year, I was called as an examiner for the first FIO BMS exam. Me, Sravanan, Varghese and Mohan. We are the 4 examiners, and these are the people they appeared for that first FIO BMS exam. Then got a little promotion. As you know, in army, promotion is not necessarily to do with money. Money will keep on coming on its own go. But promotion is little different. So landed up in the war memorial. That day it was almost about 8 inches of snowfall there in the valley. So appointed as an advisor in the Kashmir Valley. Okay, and this is what my trauma center. It is really frozen trauma center, and from inside you see how active is this. First case, first show. Just kissing the tip, gone out. Fortunately, not much of damage. Here, okay, 1 bullet, entry wound. Look at the entry wound and exit wound. Look at the other bullet. It is just lying inside. Okay, exposed. Marginal mandibular is saved, not damaged. This is the bullet. Post-op. Yes, another case, bullet entry is through lateral canthal area. Oh, it couldn't travel much. With the external auditory meatus, it has got stuck because the rim of the external auditory meatus is very thick. So it has got stuck there. Here is the bullet and reduction and fixation of the left zygomatic arch. Hanging face. We didn't have much facility like CT scan and all these things. in early 2000, we didn't have all these modern amenities. So with your clinical acumen, you will have to judge these cases and treat these cases. So started like this. This is the entry wound, exit wound, aligning each piece. There is nothing called ABC. It has already been done. It is only exposure and fixation. Airway, breathing, circulation, it has already been managed at the primary stage. The cases have been referred to you. Okay, so this is what we finished with. Early recovery. This is the radiograph, and this case has come up for a follow-up after 15 years. Look at the same gentleman, and fairly good job done. I feel after 15 years, this is the state. Okay, so yet another case, half of the portion of the mandible is missing. Look at the entry wound and exit wound. Simple reconstruction plate. Okay, another entry wound, exit through the roof of the palate, came out on the left zygomatic area with mild facial palsy. He survived well. Yet another case, open it up after debridement. Start aligning one piece to other. First is the orbital floor reconstruction with a mesh. Then is fixation of maxilla. There is no such logic top to bottom, bottom to top, right to center, center to lateral. Nothing happens there. Do it the way you are comfortable. You feel that you can do it that way. Okay. So aligning pieces of mandible, jigsaw puzzle. Fairly good outcome. No flaps, no skin transfer, no soft tissue transfer. And here is the post-op radiograph. Occlusion is stable. Yet, this man has taken a bullet on his left eye. One thing very interesting with the Indian soldiers. All these bullets, they have taken it from the front. None of the bullet, they have taken it from the back. That is very interesting as far as the Indian soldiers are concerned. Taking the bullet on the left eye, look at the state, try to specify the common carotid, both the sides, almost 30 units of transfusion. This gentleman bled almost 12 liters, 6 liters of his own, 6 liters of transfusion. Unfortunately, it's not possible to salvage the life at every time. So my total statistics is 126, out of which 21 death certificate we had to sign, in which we had the facial concert wounds or the splinter injuries. All the same, you have a little fun also, that the first time in Srinagar Valley, your tulip garden was inaugurated. So be happy to be invited there as a guest, and then taking a heli ride to the holy Amarnath cave. Okay. So from a very hot place, from fire to the fry pan, I was put in the ADCRR. You know, ADCRR is a very, very difficult place. Means in no time your career is spoiled, or in no time your career is made. So choose what option you have got. So much of political vibes from all around. You name a politician who is coming to you for treatment and all this thing. Okay. So there the main thrust was destruction that time. We have started with NDS program that year. So the main thrust was destruction. Starting with destruction, conventional one, corpus destruction, predetermining the position, vertical cut, putting the distractors, checking the vector, perfectly aligned distractors, intraoral placement. But here the problem what I found is this: after the mandible has moved out, the last standing tooth, it remains without any antagonist tooth. That means the maxillary second or third molar will invariably extrude, prone to caries, periodontal problem and loss. So this is the problem now. You see the state of the upper second molar. Distractor removal and frontal right and left profile, and this is the occlusion we started with, this is finished with. Here is the problem what I said. Tooth number 7 is without any occlusion. So to avoid that, we try to modify the osteotomy cuts. Here is a class 2 presentation, tip bite, all 32 elements intact, 32 teeth are intact. We modified it to the BSSRO. First, put the distractor, align the position, do a sagittal split osteotomy. The vertical cut is through the foot plates of the distractor. Placement of the distractors, activate it, and in the proximal segment, use the smaller screws, 5 to 6 millimeter. If you use the longer screws, it is going to interfere in the distal segment. So the distractor will not get activated. So that you must use the smaller screws in the proximal segment. Yeah, activation confirmed. Look at this. Look at the position of the 8. This is after 10 millimeter of distraction. Still it is in the occlusal contact. Even if the third molars are partially erupted, let it be there with 10 millimeter of lengthening. It has got enough of space to erupt. That we have seen. So this is the occlusion. Removal of the distractor, asymmetrical distraction, 9 and 11 mm. This is what we started and finished. And this is the comparison. That is the vertical body osteotomy versus sagittal split ramus osteotomy with distraction. So what we found, third molars are generally preserved. Maxillary second molars are always in occlusion. Minimal bone loss in SSRO. Osteotomy site is always anterior, hence it is very comfortable. Then is access is easier. Inferior alveolar knot damage is minimal. Callus width is maximum. Rate of distraction, instead of 0.5 into 2, we can go for 0.5 into 3. That is 1.5 millimeter per day. Distractor removal, you can do it under LA, and duration of treatment is shorter. Okay. Another problem what I observed is the hourglass deformity of the corpus. In a vertical osteotomy, once you try to stretch, look at this anteguinal area. This is called hourglass deformity. Whereas in BSSRO, you don't have the hourglass deformity. So this comparison, I presented it in Kochi and it won me the best prize. That was the joint venture with BAOMS and IOMS held in Kochi. This function is in the Bulghati Palace. So that was the Jinbala trophy. And in fact, my resident, the way they drank that day, I didn't get a single drop of alcohol. Totally it was a dry day for me. So but fortunate, these people, Ajay is heading now AFMC, Vishal is heading now RR. So it's a moment of get pride. Then in RR the expectation was furthermore, like microcephaly, syndromic children, another thrust area. So there look at the increased ICP, bitten copper or the golf ball appearance of the skull, doing a strip craniectomy of 10 millimeter, choosing a 20 millimeter distractor, activated by 10 millimeter, leaving only 10 millimeter. This is what 20 millimeter of anterior position in the frontal bone. And look, the pre and post. Much better cognitive behavior, growth is adequate, response is also very good. So after 3 to 4 years, again from RR, I was shifted to AFMC as a HOD. There in AFMC, you are a HOD for 4 departments: ortho, prostho, perio, oral surgery. You sign their dissertation also, you are responsible for their academic activity also. So with that, our project was on class 2 deformities, the TMDs. Typical case of TMD with class 2 deformity. Look at the condylar position. Model surgery, simple BSSRO and repositioning the proximal segment. And incidentally, this lady is totally free from the TMT following the BSSRO. Yet, challenging cases of bypass surgery. Here, the target which was given to me by my orthodontist is this. There is a retained 55. So there is a submerged 15, impacted 15, and there is a retained 75. So there is an impacted 35. So what their target was, look, this is the 15 and this is the 35. This is the CBCT. This is the digital prediction planning. So their project is, you remove 55 through leaf out 1. Do the extraction of 1/5, make a socket tied to transplant. This is one of the target. And the other target is remove 75, remove some portion of the bone from the coronal part of 3/5 so that the orthodontist can put a bracket and try to pull it up. So be it so. Now you look at this. Look, 5 is in place. 3/5 has already come in place. The target is achieved. This is what you compare the pre and post. Oh, a page 3. So page 3 means very demanding. Cross bite, bijaw. Look at this black triangle. This was very difficult to convince the patient, but ultimately the orthodontist did a very good job. This is what we finished with. Post-operative safe as well as lateral profile. Then come to raised external distractor. We had few projects going on the distractors, so this is one among them, particularly in cleft cases. Look at the jumbled anterior teeth. We don't believe in too many extractions. We try to do the extractions minimum, so that let the orthodontist prove their worth by putting or by aligning the teeth. So here, as per the plan, we wanted to remove one supernumerary tooth. A mesodense is here. If you can make out, this is a mesodense, and this tooth we wanted to extract. Barring these two, rest all we intend to keep it. Okay. Now the supernumerary is gone and the premolar is gone. And with alignment, the oronasal communication it worsened. Okay. Then splint, RED, transnasal fixation, that is 1 mm a day for 10 days, 10 mm, retention with reversible headgear. This is the finishing. And this is the occlusion we started, that's the occlusion we finish. As I said, there is a worsening of the oronasal communication. Then we planned for an anterior tongue flap to obturate that oronasal communications. Hence, there is no nasal regurgitation. Yet another case, almost 18 mm of maxillary advancement with RED. This is the comparison, pre, during and post, and this is what we finished. So these are my team of orthodontists, including JS. They tasked me for various difficult surgical tasks, and we just try to keep up to their expectations. Syndromic children, peri-Robbins sequence. This child on NG tube feed since birth, 6 months old child. This is the state of mandible, very small mandible. Putting a distractor extraorally on a reverse pattern, monitoring the callus. Look the way the distractors have been placed, upside down. And this much distraction we have achieved, putting almost in cross bite and follow up for next 6 years. Syndromic children, Apert syndrome. Look at the forehead deformity, collaborative project with neurosurgery, typical spectacle frame, harvesting of the calvarium, reshaping, putting it back. Look at the amount of gap which has been created. Just trying to show you the supraorbital gap which has been created here. And look at the shape of the head. She never came back for a Clifford 3 as on date. Okay. Then is Eagle syndrome. Look at these two styloid processes, more than 45-46 mm. That is through intraoral transpharyngeal approach, paratonsillar transpharyngeal approach. One is around 44 mm and one is around 28 mm. Remaining portion it broke, we couldn't retrieve it. But all the same, it remained in place. So as long as I am going intraorally, it was not possible to explore to that level. Okay. Then we spoke of implant. Putting small implants, implant retained auricular prosthesis, thinning the soft tissue because the scalp is very thick. Castable abutments, bar attachment, and bar and clip retained auricular prosthesis. So friend, along with that, time and again we have been assigned with the administrative duties. This is one among them, conducting the NAC. NAC is very scared to visit us. So here is the NAC visit, briefing the NAC, briefing the foreign visitors. Receiving the VVIPs, because the officers mess with 200 guest rooms, it was assigned to us, to the department. The naval chief, the army chief, and here is the sports minister of the country. Then is the former army chief, and you say something, you are in the print media. For good reasons or bad reasons, whatever is there. And if Fauji is saying something, people they try to take it in a very negative way. Look, this is a statement given by these people. Okay. And meeting friends, of course, losing Raman Sinha prematurely, it was a very setback for me, my batchmate, my coursemate. Okay. And academic publications. Tuesday Dental Clinic of AFMC. We brought out second and third editions, though of course now it is 7th edition is going on. This is our own creation. As per the NMC norms, you have got 19 classes to be taken for the MBBS students. I compiled those 19 classes, distributed this booklet to all the AFMC cadets. That is the Handbook of Dental Sciences for medical students. Okay, this is the best ICAMR project for us. Me being the principal worker. Then got a request from the UPSC to be empaneled as the advisor. This is the request from the UPSC. And with that, again I got a promotion, went back to Chandigarh. In Chandigarh, I had 8 states to cover, about 2 union territories with all administrative responsibilities, and looking after all the dental officer and the paradental staff. So these are some of the visits to the Rajasthan AOR, Chandbaudi. This is Jalna Tiger Reserve, Leopard Reserve. Yes, in Golden Temple. Yeah, this is the motor train, very comfortable. Wheresoever you want, you can stop it, have a cup of tea and come back again. Manikarnika, then Rohtang Pass. Hemis, this is the war memorial, Kargil war memorial. Then is the Khardungla Pass, Magnetic Hills. Then Nubra Valley. Then Bang with the neighbors. I am very close to my neighbors. Okay. In the 3 idiot points, that is the Paganso Lake. One idiot is endodontist, one is a prosthodontist, and the third one is here sincerely. Okay. Then go further to the north. This is Holy Kailash and this is the Mansarovar. So then suddenly the Endodontic Society, Implantology Society, they wanted to felicitate me with a lifetime membership for that Academy of Oral Implantology. That was in April 2022. So after Chandigarh, I came to Lucknow. All the academic and all the professional activity it keeps on happening. In a month, I operate for 20 days, and in 10 days, you are supposed to visit all these places to see who is having what sort of problem, what can you do to improve their work conditions. So that is what Agra. Okay, this is Mahakumbh 2013-2025. Okay, that is on 14th of January 2025. And this is 2013, seeing Mahakumbh from the command center. Okay, this is your Rambada Kabir statue, Kabir Samadhi, Orcha, Sanchi, going back to KGMC. Oh, beautiful ladies of yesteryears, of course they are beautiful. And the Dean of KGMU, my batchmate, unfortunately he died during the COVID, Anil Chandra, interacting with the VC KGMU, ML Bhatt. He has always a problem that each chancellor, they prefer to come to us for treatment rather than going back to KGMC. Okay, spiritual salvation, one of my intermediate roommate, he is a PhD in genetics, quit everything in Nirvana mode, Kriya Yoga Yogi, Swami Nityanand Swami. Then final go at CMDC Pune, Savarkar cell, in cellular jail, Talkaveri, Mysore Palace, that is in the Aerospace Medicine Center. What you call 4G, 5G, in the aerospace also they do measure 5G, 6G. So this is the prototype where they test 4Gs and 5Gs. Kevadia, Statue of Unity, Adleja, and this is the Kanla port, watching the oil reservoir, Sunset Point. This is Sasangir. At the entry we could meet a couple of them. Okay, Sravan Belagola. Then Puducherry, another my roommate, heading pediatrics department in Jipma. This is the beautiful captions what I got from the Puducherry police. Wear this or this. What is your choice? Okay, this is the Astamudi. Okay, feeding elephant in Guruvayur Sanchir. Okay, then Ayyappa Swami Saranam. Meeting Dr. Dhoble in IDA headquarters. Looking at Taj and India Gate from the deep sea. Now you look, a beautifully camouflaged owl. No, what I mean to say, a beautifully camouflaged submarine. Okay, which hardly you can make out. Then Vikramaditya, this is the carrier. So with all these achievements, in 2020, my first presidential award was given to me. That is in the form of a Visist Seva medal. The work didn't stop there. This is looking at the Hooghly from the dining hall in Nathula Pass. Look at the Chinese are shooting you from behind. And this is the place Indo-Chini meeting takes place. Flower Valley of trying to bind the yak. And floating on Brahmaputra, because we had some assignment in Majoli. So that is the floating on Brahmaputra with your all paraphernalia. This is Buddha's birthplace, Lumbini. Pulling Nandi Ghosa, that is during Rath Yatra at Puri. And passing under the Howrah Bridge. Then finally, having a look at Delhi from the top. This is top of the India Gate. And from there you look, the right side is the North Block, South Block, and the center is the President's House, and the center is the Kartavya Path. Okay, this is on the pilot seat. I just leave it to your imagination which plane it could be. I will not tell you that, but I just leave it to your imagination. Okay, then going to the war memorial and addressing my troops, 700 dental doctors from all the specialities, about 2,500 of parental staff, interacting with chief administrative responsibility of the ACDS, Army College of Dental Sciences. It is supposed to be our baby. Then meeting with the directors of the Maulana Azad, because I am one of the governing council member of the Maulana Azad. Then with my academic performance, 174 publications with H index 20, I index 41, more than 1400 citations. I have been awarded Lifetime Achievement Award by the AOMSI. So another high point in the career, that I have also been appointed as honorary surgeon to the Honorable President of India. So this is the interaction with His Excellency Dr. Ramnath Kovind, and enough privileged to treat 4 presidents of India consecutively, also not to name the other politicians. Then the penultimate career, that is the highest civilian award in 2022, that is the Param Vishisht Seva Medal. Central Hall with a group photograph. Finally, at a very prime age, we retire from army. Unlike you people, once you are stick to a setup, you are there for 25-30 years. No. We change place in every 2 years to 2 to 3 years. Every place you go, you will have to prove your worth again and again. Okay? Then after that, Madanoresan, that is in Coimbatore. Okay? Then due to my contribution for obstructive sleep apnea, long time back we formed a society, IDSM, Indian Dental Sleep Medicine. Finally, we merged with the Indian Sleep Disorder Association, which is headed by Dr. J.C. Suri, a pulmonologist from Delhi. Then tried my venture in a private institution, that is the best faculty award for the year 2022. Now the type of referral what I get, or my practice is limited to the referral cases from the neurosurgeon and from the plastic surgeon as well as from the ENT surgeon. This is just one such case, is a giant osteoma of the frontal sinus. So if you look at this, it is already pressing the eye wall. Already you can make out this dent. There is a breach in the anterior cranial fossa, that is the posterior wall of the frontal sinus is breached. Orbit is in danger, and in fact she already has headache and blurring of the vision. The girl is only 13 years old. So osteoplastic flap, yesterday we are just discussing about this. This specimen is just weighing 42 grams, that is the size. So this is the post-surgical X-ray with 2 microplates for fixing the osteoplastic flap. So friends, to conclude, first and foremost, being a soldier, what is expected of you is your professional competence. There is an ethical conduct. How do you interact with your juniors, with your colleagues and with your seniors? That is paramount. And how do you interact with your patients? You can't go to your patients heavily dressed, your nails are long, you have not shaven, you have just smoked and you are trying to interact with your patient. So these things are strictly no. So ethical conduct is must. Honesty and integrity. Whatever has happened or whatever is done, you must be very honest with your patient, because that is your bread and butter. You can just tell lie once or twice, but every time you cannot get away by telling lies. So that is another point today. Moral courage. Like if something has gone wrong, you must stand up and say, yes, this has been done by us. Physical and mental fitness. Fortunately, I don't know how frequently you do the emergencies. Yeah, there is not a single time in 24-hour cycle where we have not operated. Often, say about 12 hours a day, 15 hours a day. So physically and mental fitness is one of the most wanted thing as far as surgical field is concerned. So this is at a junior managerial level. So once you grow higher, then what thing it matters is your power of communication. How do you interact with your seniors, with whom your speciality it all depends upon? How do you interact with the ministry, from whom you expect some funds for your association or for your organization? There is the organizational goal and responsibility. Organizational goal, what is organizational goal? How many of you do remember Lajpat Nagar blast? Yes, I have my own share of cases from Lajpat Nagar blast. How many of you have remembered 26th November 2008 Mumbai blast? I have my hands full in 2008 bomb blast. And of course, withdrawal of US from Afghanistan, that also our hands were full. So that is my organizational requirement we have to meet. Then is taking the responsibility. Like, you know, the COVID time, Indian Army was given the responsibility to open Vallabhbhai Patel Hospital there in Delhi. It was the biggest, largest hospital in the country, handling more than 5,000 patients in one go. That was the state. In the dental setup, my responsibility was the logistic supply to this hospital. Logistic means admission, ration, beds, disposal of the dead body. So one such thing, one patient was admitted to cubicle 37 and subsequently required some ventilatory support, shifted to 38. Okay, and second patient was coming to 37. After 3 hours, 4 hours, the patient's relative they came. My patient was in cubicle 37, what happened to this? So one of the dental doctor was on the duty. Confirmed, cubicle 37, how is the patient? Oh, the patient is no more, died. Conveyed to the relatives. Cubicle 37, patient is dead. But the fact is, 37 has already gone to 38. 37 is not the same patient what they are talking of. Confirm, reconfirm, lot of event cry. So what do? Own dental officer, 12 o'clock in the night, put on uniform. Go there, specify them, tell them, friend, yes, this thing has happened. I am responsible for that. But be happy that your patient is alive. So that is what, once you grow in the channel, once you grow in the echelon, you need to learn how to take responsibility for the juniors. If my junior does something wrong, that means I am responsible for that. He must have done or she must have done. So, gentlemen, with this also you need to develop some amount of administrative acumen. That is the higher managerial skill. So, with this, I feel I am really proud to be a maxillofacial surgeon. इसका साउंड दो, इसका साउंड दो. इसका साउंड दो. हाँ हाँ साउंड दो इसका. चलो इसका साउंड दो ना. Some sound is not coming. Sound नहीं है? Okay. Sound तो इसको. No, I don't think the sound is. चलो छोड़ दो, कोई नहीं, either you do this or you do this. Don't do both the things together. No. So this is that ceremony in the President's house for the award of PVSN. So thank you gentlemen, thank you very much. So that is what I mean to say. Soldiering. Soldiering is one of the most difficult job that you feel. Not being a doctor, but as an administrator, as a human being. And here, the family takes a backbench. Because I have got a very large family. Country from tip to toes, from east to west, from north to south. Along with that, we had 8 UN assignments. South Sudan, Lebanon, Tajikistan, Bhutan, Imtrat. So that also is our responsibility. Means that is the Government of India's responsibility, is our responsibility. Thank you gentlemen. Thank you very much.